I witnessed, recorded, and produced these videotapes of the Washington, D.C. hearing. Their authenticity is above question.
This is produced as part of the ongoing work on the website, thewaythetruthandthelife.net.
This is a hearing about the government licensing the electrocution of people to cause grand mal seizures. Think of the millions of dollars, taxpayers' money, spent to pay psychiatrists and their supporters and for the worldwide travel in putting this conference together, while the victims and opponents had to pay their own way.
They have a bad smell about them. These are called delusional depressants. It's among this most severe group, and especially the delusional depressants, that the data is the greatest and most intense, showing that there is efficacious use of ECT, that they can be helped by this. Mania is a condition which superficially resembles the opposite. People tend to be hopeless or completely happy. Actually, the manic patient is a person who's out of control, hyperactive, restless, can't sleep, thoughts racing, and unable to concentrate, feelings of grandiosity, able to do anything, will start many businesses, open numerous bank accounts, and are essentially inappropriate in terms of their attitudes about themselves. A subgroup of those patients that are manic are indeed characterized by symptoms of being so restless and that they can actually develop fever, and we are concerned that individuals with very intense mania out of control often do not respond to other medications and have ECT. And that's a fairly small group of manic, but still very impressive.
Is ECT separate from a more public image?
We should bounce around the questions, I guess. Yeah.
Dr. Rose, as you well know, there was some feeling among some of the former mental patients here, and at least one of the physicians, that this panel, because of their particular careers, their jobs, and their stage in organized psychiatry and psychology could not be objective in evaluating ECT as a treatment. How would you respond to that after this 3-day meeting?
The members of the panel, we're 9 physicians, 3 psychologists, and 2 members that are supposed to be public representatives, one of whom is a lawyer and one of whom is a past editor of books for Consumer Reports. The physicians on the panel were solicited expressly because of their lack of a established opinion on ECT, their lack of having done research themselves, and having, quote, staked out where they're coming from. The group came with an open mind, trying to assess what the risk and benefits were for ECT. We spent a good deal of time talking about the balance of risk to benefit ratios. And I think that is documented in our report.
I might get thrown out, but that statement is not true. I'm looking at a panel member that was at the FDA hearing on electroconvulsive devices. His opinion is well known to everybody. How can you say that?
I'd like to give a personal anecdote of my own, which was not known when I was selected to be the chairman of the group. Well, there's no question in our minds that there are a significant number of patients who have had significant side effects and memory deficits associated with ECT. It's also very clear to us from the testimony of other patients that ECT can be tremendously efficacious and helpful to them. And I think that it's very difficult for us to use the data from Great Britain, but that's where the most systematic data is collected. I wouldn't assume that one could translate those numbers to be exactly equivalent to the United States. However, when systematic studies have been done, a varying percentage of patients are positive or very positive about ECT, somewhere varying between 60 and 80%. I don't know if that would be found in this country. Nevertheless, there are significant numbers of patients who have benefited from ECT and have spoke to that point, as well as those who have very bad experiences. So I think to propose a moratorium would be to deprive patients of the therapeutic efficacy.
Well, along those lines, how do you react to the vehemence of some of the patients who have been attending these meetings? How would you account for their vehemence?
Well, I don't know if I can account for it. I can speak to it just very briefly. I think that there are a lot of factors that are involved in why ECT is a very controversial treatment. I think that many of the patients themselves spoke, I think, rather articulately, that many of their concerns relate, of course, to ECT itself, but to the nature of the process in which they had ECT. And their experiences were that they were never informed of its effects, they were coerced to have ECT, and when they complained they didn't want it, they were told that terrible things would happen to them if they didn't take the ECT treatments. And I think that those factors can certainly help them understand some of their intense feelings. Yes, sir.
One of the study panel's recommendations is that we do more research on the long-term outcome of patients who have been treated with ECT. And I spoke with Dr. Goodwin, the scientific director at NIMH, and he told me that he would like to see data available about the medium-term and the long-term effects of ECT, whether it reduces recurrences in patients and whether it has any long-term advantages. And he is of the opinion, as he told me, that the reason this research has never been done is because ECT evolved in the era before controlled studies were being widely done, and it predated the research era. Is that your interpretation of why such research hasn't been done yet?
I think that's a very important factor. I think there's some other factors. If we look at the British study, what they have done in some of the very best studies where they compare ECT with sham ECT, which is everything but the actual administration of the current, that the ethical constraints that are imposed and should be imposed require that individuals not be placed in a no-treatment situation for more than a 4-week period of time if they're seriously ill enough to be considered as candidates for ECT. So consequently, those studies did follow people for 4 months, for 4 weeks, and showed advantage of ECT. The situation becomes complicated after that because those who had the sham treatment and the real treatment both had access following the 4 weeks to other treatments because of ethical and considerations. So the long-term effect is not clear. However, I think it's also fair to say that in the period of time following the 4 weeks of treatment, most of the patients remained without a relapse, although many of them were on other medications.
Dr. Stone, while you're speaking about the British experience that came up during the conference, that the British typically give this treatment twice a week, whereas in this country it's typically given 3 times a week. And it was also mentioned by somebody that there seems to be less memory loss in the British experience than with the American experience. I wondered if you considered a recommendation on that score. The other thing I wondered is if the administration of the anesthetic that is done these days in conjunction with this increases the seizure threshold so that you have to give larger electrical doses.
The last question I'd like Dr. Liberty to comment on. I'll probably comment on the first one. I think there's, although the average may be 3 in one country and 2 in the other, there's significant variability, and these are trends. We do not have the exactness of the data the British have, because they conducted a very careful national survey in 1980. We don't have that comprehensive data. Dr. Lippert, would you like to answer that question?
I may have missed part of the question, so I'd appreciate hearing it again.
These days, as I understand it, a brief general anesthetic is administered in conjunction with this treatment on humane grounds, I presume. Does that increase that in the setup of increase the seizure threshold so that you have to use larger doses of electricity to deliver to the brain?
That is a very good question, and there are a lot of problems I think that we need to clarify about electricity to the brain. At first, I should mention that general anesthetic is very short-acting, and the kind of anesthetic we use, Brevitol, actually is used by epileptologists to try to stimulate seizures in patients, or at least try to help electrical reporting loss. So if anything, we don't know for sure, but if anything, they'll expect it to lower the dose, but we don't have proof of that. The second, I think, great misconception is the fact that very little of the electricity that is actually given gets into the brain. Only about 2 to 4% gets into the brain. And so when people use these incredible analogies about this tremendous amount of energy that's zapping the brain, so to speak, it's really incorrect. And much of the electricity does not penetrate the skull. It gets diffused around the scalp and the skull and goes into the musculoskeletal system. And anesthesia is necessary to prevent the convulsion or the generalized tonic-clonic seizure, which in the past had been associated with bone fractures.
But the other thing was that somebody mentioned that Brevitol, although it is the anesthetic of preference, is not being used by many centers in this country, that instead they're using sodium amytal or whatever.
Are you recommending that
We
they
do
use
not have
her?
data on what the incidence of use is, but my suspicion would be that most use Revitol because the literature is very clear that these have been double-blind, randomized controlled trials with Latin square design, showing that Revitol is there.
What percent or portion of psychiatric patients are you recommending that ECT is an effective treatment for?
That's a very simple question, which I can't give a very simple answer to. What we are really, and let me digress a moment if I can to try to explain why I can't give you a simple answer. I could multiply the population by the incidence and prevalence figures of individuals with various diagnoses and those subgroups who are very severely ill. However, what we have tried to make clear in our report is that the issue of giving ECT should be made on the basis of the individual patient situation. There are a variety of medical conditions where people can't take drugs. Drugs are often strenuously avoided in the first trimester of pregnancy. Many patients with serious cardiovascular problems cannot take drugs. We think it's very important to evaluate not only the patient's diagnosis, but what his or her clinical situation is, how important it is for them to have a more rapid acting agent, and what other medical or personal considerations must be taken into consideration. Consequently, I can't give you a real figure. We don't know that. And I think that it would be dangerous and probably an error to say that we know that X number of people need ECT in this country. Our whole approach is then is to try to look at it from the individual patient's perspective. Yes, ma'am.
Could we get counts? I think we all have some question about whether your consensus statement would lead to an expansion or a restriction of use of this. I don't know whether, again, if you think there's some data on that, we understand that. I don't know whether anyone else there has an opinion about whether it's underutilized or overutilized. And also, if you could address the question of variability, whether you think there needs to be more regulation of the machinery or of the practitioners who are using it.
I think that the first two are both right. I think there are places where it may be overutilized, and I think that there's data to support that there may be institutions where it's underutilized. But consequently, it's very difficult to get an average to know if our recommendations are followed, whether it will be a net increase or decrease. We do feel that it is important to develop standards about the administration of ECT. We do discuss this in our report. What we would like to suggest is along the lines of what Professor Rothman presented during the consensus conference, namely that he clarified, I think, in a very reasonable way, the fact that ECT has not been subjected to or not enjoyed the kind of review by peer review committees existing in medical centers or hospitals that other medical surgical procedures enjoy. And I think that our concern is one, to collect some information about the variability and how ECT is used, the nature of the machines that are used, and to get some better understanding as to how widespread misuse is. We do feel that it is a powerful treatment. We do feel it's an effective treatment. We also have very good information that various parameters, various ways the treatment is given can affect the magnitude of side effects. And we're concerned about the magnitude of side effects, and this is one of the reasons that we want to collect, we recommend that information be collected as to variability. And I think that this would be a very important start.
When you say collect information, does that suggest that new studies on animals? I noticed there's an absence of suggestions for animal studies. We've got 45 years of research or experimentation.
What I'm specifically saying, what I've alluded to just a moment ago in response to her question, was that our recommendation is that we collect information on how ECT is administered in the country, systematic information, as was collected in Great Britain by their study in 1980. We do believe that experiments should be done in animals. We do believe that animal studies are very important to help us elucidate what the mechanism is of why ECT works, how it's effective. And we state that, as a matter of fact, in our recommendations for research. Ms. Mann.
If I could just sort of re-ask her question in a different way. I think maybe what she was asking was, what percentage of mentally ill in this country suffer the kinds of disorders which may or may,
which you feel should be in that group that would be responsive to ECT. How many people would be affected by your recommendation that you might possibly be effective treatment for them?
I'm not being cagey, and I'm not trying to squiggle away from your question. It is possible, because we have good information that's been collected both historically and been validated and clarified recently by the epidemiological catchment area study, surveying about 20,000 individuals in 4 cities. We have some understanding about the prevalence over a 6-month period of time of those individuals who suffer from major depressive disorders. That's about 3 to 4%, higher than women and than men, and varies some with age. That's an average. We're also aware that we have some information about the number of those people with major depressive disorder that have more delusional symptoms or were more intensely ill with what we call the endogenous melancholic subtypes. The problem is, I don't think it would be reasonable to extrapolate by multiplying that figure out and say all those people need ECT.
I'm saying our candidates might be in the pool who might be considered by doctors on one individual basis.
Generally not an indication for ECT. So that a very large percentage of the people who by diagnostic criteria have a condition for which ECT is efficacious on clinical grounds would not receive ECT. So I think any number is going to be misleading. Also, one must realize that it would vary dramatically from setting to setting.
Yeah, but we need, for those of us who are writing stories today or broadcasting stories, we need to have a sense of how many people can be affected by your recommendation. Can you just give us a range?
I think I'm saying that we can.
Would this figure be helpful? I know that you want a figure, and I was aware that you would want a figure, and we thought about what we could give you, and we don't know what we can do responsibly, and it's not just being elusive. 2.4% of those individuals admitted overall to all psychiatric facilities received ECT in 1980, or 33,000 plus treatments in that ballpark. Now, I can't tell you whether that figure is 1/2 of what it should be or twice what it should be. I think that it may increase some or decrease some, but the most important issue, I don't think we can reasonably tell you that there's that amount of pool out there that these people are really being deprived of ECT. I can't see that.
But it is fair for us, to ask the question as to what candidate pool of people that suffer from these disorders. We are able to write in our stories or broadcast them and say, you said that they might not all be candidates, but when people read about this and they have severe depression, they'll say, well, would I be a candidate? They might ask their doctor. We're asking for what that sphere of people might be. And also, you didn't really say whether, you sort of said in the press conference that it implied that it should be a treatment of last resort. I heard you say this morning that you didn't really have a consensus of that. So I think it's fair for what this morning in the session, I thought you equivocated on that day when you gave your opening statement. It seemed to say it was treatment more of last resort. I was a little unclear on that. But I think it's fair for us to press you a little bit more about, for example, how many people suffer from severe depression, mania, and some of the times schizophrenia that might be considered within that individual clinical setting. And we'll say many of them will be treated with drugs first. But I think
I am very concerned that anything that I give will be printed as X number need ECT, and I'm very concerned about that. And now maybe that's my imputing inappropriate behavior to you, but I'm concerned. Perhaps I can share this again with some other members of the panel later. Dr. Jameson, would you like to talk back to that? Thanks a lot.
No, I entirely agree with you. I mean, you can give statistics. We know the data on epidemiology and the major depression.
Do you know that? You should answer.
Okay. But yes, I think that's public information. I mean, 1% roughly have bipolar manic depressive illness in the general population. Roughly 5% have major depressive disorders. A large percentage of those people are going to be very well treated by drugs or by psychotherapy or by the combination of drugs and psychotherapy. Won't ever need ECT, won't ever come anywhere near the possibility of ECT, and I think that's the concern that all of us have.
Well, I think we're responsible journalists. understand the concern of the sponsoring experts and pointing that
Those
out.
figures-
Of course, but we have to have a sense. I mean, you're coming out with statements here today. We have to have a sense of how many people could possibly be affected by what you're saying.
By expected, we don't mean they're going to get it. We can go call the National Institute of Mental Health and get adequate information. We, as a public service to us, we want to have that.
We have several representatives of the National Institute of Mental Health sitting in the audience who are, I'm sure, have all these statistics at their fingertips. And if you'd like, I'm sure they can give you those. We are concerned about the way the question has been asked. And we cannot say that X percent of patients with a given diagnosis would represent X, Y number of people need ECT. Perhaps,
No one's asked that question.
would someone else try to, I'd be glad to have anyone on the panel try to answer them differently if you think that's a better way to go.
I think certainly a very, very meaningful question is the question of whether this is a treatment of first choice under some circumstances. And I think it's very clear, and I think Dr. Rose and the entire panel agrees that in some circumstances there are certain life-threatening manias that result in exhaustion if they're not treated immediately and don't respond to medications. That's one group of people. Another group of people are people for whom MAO inhibitors or tricyclic antidepressants cannot be prescribed. This is a very important group of people. I don't think anyone really knows the order of magnitude, the number of people involved, but they're a very clinically significant group of people.
Well, so for an order of magnitude,
What about the FDA question of reclassifying? The APA has suggested and asked for reclassification of these drugs. Would you recommend reclassification to a lesser restricted category?
We did not enter into discussion about the restriction, about the reclassification of that issue. That was not a part of our charge. We were not provided with systematic information about that. And I don't think we can give you an answer because we did not debate this and don't have a consensus on it.
The question of suicide.
Yes.
You indicated in your statement from your own experience that there was a great deal of overutilization going on of ECT. You were saying when you went from Boston to Galveston to take on your new position, you found a great deal of overutilization in your particular position. Does that indicate that this problem might be repeated many other places and is more severe than your statement indicates?
Well, I don't know. I don't think we know. We don't really have the information. It's certainly possible that in certain institutions, ECT may be used in what we feel, according to our guidelines, is excessive. However, it would be, I don't think it would be reputable for us to say that we know the information as to how many places there are. The fact that they may exist, absolutely. The fact that there are varying standards in the use of ECT, varying sophistication, we also feel that exists. But there is a really absence of hard data about that issue.
It seems to me also not absence of hard data. How about women versus men? More women than men. Who is the person that's been getting ECT?
Women have more depression. However, it was pointed out by Dr. Thompson of the epidemiology branch in his presentation to the panel on our opening day, whatever that was a few days ago. The fact is that women still are overrepresented by the amount of ACT they get when one corrects for the percentage admission. So women do get more ACT than men. Current data that's obtained in 1975 and 1980.
the press and Hollywood have generally been blamed for the bad image that ECT has. To what extent do you think that's because of the old-fashioned image of what ECT used to be?
Well, I think that Cuckoo's Nest was a very powerful film, and I've seen it several times. And that's probably one that comes most to mind. It still plays on cable frequently.
Was that depiction of ECT entirely wrong for the time period that it was set in?
I think that there were many aspects of that which were chilling and upsetting to modern-day psychiatrists. I think that what happened in Cuckoo's Nest was a lot of things that happened. ECT was unmodified. We don't do that anymore. But more important and probably more subtly and more grabbing than that was the coercion. And people were grabbed, not given any choice, and it's something that happened to them.
But on the technical side, what about the technical aspect of the convulsions that body?
Those were very brutal. And the fact is that ECT, before we had the induction of general anesthesia, before we had muscle relaxants, before we learned to modify the current, was a bone-cracking kind of experience. But again, I think it's only fair and judicious to place it in some context, and I don't use the context of the coercion as fair, but the context of the fact that in the 40s and 50s, we had no treatments available that were effective outside of ECT for controlling very disturbed behavior. We also are aware, however, and we say in our report, that not only was it used for controlling disturbed behavior or suicidal behavior, it was also used to control behavior. And that is also a major problem, and that has to be acknowledged. Yes, sir.
You were talking about underutilization earlier and mentioned that state hospitals were expanding, federal level, federal administration hospitals expanding. How did that come about? And does your statement suggest that the federal policy prohibiting it is not keeping the state on that?
I think that's correct. We think that absolute prohibitions of ECT are unwise. We think that there's considerable data to suggest that over the course of the last 5 to 10 years, because of the controversy about ECT, because of people's concern about it, because of its obvious negative image, that public institutions have moved away from administering ECT to their seriously ill patients. It is a problem for the patient. And we know, for example, that black students do not get much ECT compared to whites, compared to the percentage of diagnoses that they would have, balancing that out. And we know that individuals who are institutions, public institutions who do not pay, do not get ECT. And so that the other side of the coin is that individuals without resources are denied ECT when this is appropriate, just using epidemiological data. We do not have case reports. This is just arguing from the distribution by private institutions and by race.
Dr. Rose, there seems to be a tremendous lack of information. I mean, if you listen to what you have said and what the other panelists have said all day today, there has been more I don't know than anything else. And as a human being, I find that it's very difficult to understand how you could advocate this procedure very much when there is so much I don't know about it. I think I would go back to a question that was asked earlier about some sort of prohibition or slowdown of the use of this stuff until you've done more research, until you know something. Tell me why I'm wrong.
Okay, fair question. The reason that you're wrong is that there are a significant number of studies, very clear in the literature, that show that ECT can be a very effective treatment for a variety of conditions. And if individuals with those conditions are untreated, they are at a high risk for suicide, they are at a high risk for developing fever, dehydration, they are at high risk for sitting for weeks or months or even years resistant to our treatments that we have that are not ECT, like antidepressants, monoamine oxidase inhibitors, neuroleptic drugs. So we do know that there are severely ill patients for whom ECT can be a very effective treatment.
But we don't know. But we don't know how many, or do we?
Yes.
I didn't come to this being an ECT maker at all, but one of the things that's impressed me in reviewing the literature is that when you look at studies that compare ECT to antidepressants, there is not one single study among more than a dozen in which the ECT comes out as less effective than the antidepressants. In every single course of your depression, in every single study, ECT is either equivalent to the antidepressant, or it's superior. And the same is true in the literature with delusional depression. Comparing ECT to antidepressants alone and to antipsychotics alone, it's clearly superior.
So it works.
So it works. And that's impressive. And also clinically. But that can be a short life-saving period. And it also can reverse really very, very severe delusional and depressed conditions.
And is that sort of looking at it? It seems to me that those studies only look into psychiatrists.
They looked at lifting with the manic patients. I think that our reluctance and our hedging relates to a balance of two issues. It relates to our concern that A, we have an effective treatment. We also have considerable concern about the informed consent and the process whereby people have it. We believe that it's very important that individuals have a choice in this because there are side effects which can be distressing and are distressing to patients. So it's a balance between them. We are not advocating either. We're clearly saying don't shut it down, and we don't say go out and do lots of it right away. It's a very balanced reasoned approach based on the individual patient. That's the reason that we are adopting this cautious approach, to balance those two factors.
Let me ask you to restate your position.
Can I go around and back, sir, is your question?
Yes, what type of training or certification is required for physicians and technicians to give ECT? And are the people who are giving that procedure all qualified?
One of our recommendations is we need to establish standards for certification of privileging of individuals to do ECT.
Are there no standards
There
now?
are varying standards, but they're not widely promulgated and they're not followed across the board in all institutions. So that's one of the areas that we feel there should be increased attention paid. Yes, ma'am.
This is a factual question. I wasn't sure when the reference to the public hospitals came out. Is there a policy decision as to across the number of hospitals, either state or federal, against doing ECT?
I think that perhaps I don't have anyone have an exact information on that. What we've observed in the immunological data about the drop in use with the same number of patients. And we do know. Pardon me?
We have data from New York and Massachusetts that are 21 ECTs private.
I don't know the nature of what obtained to lead to this data trend. I do know that ECT dropped over 5 years. We do know that it is obviously controversial because many public institutions stopped doing it a number of years ago in the light of these controversies. I think those data are quite clear.
Well, it's not prohibited as veterans and hospitals as years ago. It's not prohibited.
In fairness to the public hospitals, they do have a higher percentage of schizophrenic patients where there's less evidence for efficacy. On the other hand, it's very hard to believe, and my personal experience indicates, that there aren't some patients in these facilities who wouldn't benefit from the ECT.
So it's sort of a de facto policy, not necessarily
And I
a
think
state policy.
it's based on the trouble involved, the expense, having to have an anesthetist and things like that.
I don't mean to harp on this one issue, just very briefly. Dr. Reagan said that he has brought data to this panel, specifically related to brain damage. Could you, for the layman in simple terms, react to his statement that there is evidence of brain damage? Is he misinterpreting the data?
I believe that reasonable people can look at the same scientific studies and come to exactly opposite conclusions.
I don't see why it's a different question. If it is a different question, tell me, and then tell me what the conclusion is as to
I think the issue of brain damage seems to be one that keeps coming up.
Could you step up to the microphone?
We're talking about a cultural issue. We reviewed the evidence available from a scientific perspective, and there are certain criteria that one needs to use to evaluate scientific studies. And we had a large number of studies available to us, and my background is as a neurologist and interested in epilepsy and brain damage from seizures has also made me aware over many years of the information that is available in terms of scientific studies. Now, in order to look at scientific studies, you have to have a very high standard of looking at how the study was done. And it is very clear to the scientists on the panel and the scientists in the United States studying this matter that most of the studies, the vast majority of the studies which showed brain damage, quote unquote, earlier had trouble with methodology. Fixation artifacts. It's very clear that if an animal or a person dies, there are changes that take place in the brain from lack of oxygen, lack of blood. So when one looks very critically, from a scientific point of view at these studies, it is the inclusion of all the scientists, I think, on this panel, and certainly the scientists I've spoken with, the ones I've met with before, that there is no evidence, and I'm going to limit the definition of brain damage to actual death of nerve cells. And there's no evidence in our consensus and among scientists that there are any evidence that there's any significant amount of actual nerve cell death from the amount of current that is used during electroshock. Now, someone earlier asked about basic science research. There are groups in the United States and England who've been studying the epileptic animals from rats to all up higher species, and they're all finding that very short-term pulses of electricity lasting less than a few minutes, or seizures lasting less than a few minutes, if there's oxygenation, there's no change in blood flow to the brain of any significance, there's no cellular damage. I want to also mention that it was a consensus of the panel that we're aware that there is a memory deficit. Now, we don't know what the neurological basis of a memory deficit is. It may be some rearrangement of some molecules that are important to memory. We just haven't been able to detect that. So our position is that there's no gross loss of nerve cells, which some people use as a criteria for brain damage.
Can you identify yourself so we have the...
Yes, Dr. Luttig from the University of Minnesota.
I have one quick question to you. And that is, on the basis of that data, is ECT safe?
The ECT being safe is a broader topic. And ECT, in my opinion, does not cause death of nerve cells in the brain. ECT very clearly causes a memory deficit, which I think is a consensus of the panel.
What's your answer to the question, though, Doctor? You have an opinion, right? Safe or not?
I think it is safe if it is used properly.
What is the cost of this therapy compared with comparable drug therapy for a similar course? And also, are the professional fees charged about the same?
There are variations in the cost of ECT. The cost of the treatment they run on an average of $75 to $150. The cost of an anesthesiologist is about $60 to $120. There are varying institutions charged differently for the anesthesiologist, or has for this time. And it's difficult because ECT can be very effective. People can be very sick for many months, or even a year or 2 years, have 3 or 4 ECTs, and leave the hospital within a couple of weeks. That can be very dramatic. That's one of the clinical experiences that many people have had, and the research data bears out that clinical impression. So one has to compare those costs with the cost of hospitalization in seriously ill patients, along with the cost of medications.
Is there any data on ECT use in children? And does the panel have a recommendation along those lines? And specifically also anorexia nervosa, someone...
Specifically, anorexia nervosa is not one of the conditions for which ECT is considered efficacious. The general recommendations of most individuals and most groups are doing is that ECT is not to be used with children except under unusual experimental circumstances. And the issue is that generally should be considered until individuals become their late adolescence. And the issue of informed consent also is very important. But ECT is not used for children now. It's very, very, very.
What would be a situation where ECT is used?
I think that when we were discussing it the other night, Dr. Clayton is not with us now, said that there are cases where a child is found hanging in the closet from a rope and is determined to kill him or herself and does not respond to drugs, and the patient is persistently and insistently suicidal. And in those circumstances, individuals have generally consulted with 3 or 4 other psychiatrists or child psychiatrists and given treatment. That's very rare. Yes, sir.
If it were possible to determine that severely depressed people were depressed because of psychological reasons, or perhaps due to a fairly accidental chemical change, would that have any bearing on the, as an indicator, as to whether ECT should be used?
We used to believe that certain kinds of depressions were caused because of bad life events, and certain kinds of depressions were caused because of changes. I think we've moved away from that considerably, and I think what we say is we don't know but that people can be very seriously depressed because something very bad happens to them, or very seriously depressed, and nothing that we can determine in their environment has gone very wrong. So I don't think that the causation speaks specifically to the issue of the treatment or treatment response. It's the intensity of symptoms in the clinical picture.
Are you aware of any plans right now to conduct clinical trials over the longer period than you recommended in your report? And if not, how long would it take for such a study to be initiated and to be completed?
Well, I don't know of any studies that are currently planned, although I wouldn't say that that was a completely accurate statement. We did not review that question specifically in any detail. And I think that it takes a while to get well-designed treatment trials up. It would take many months or a year and a half. I think that there are a variety of things, including natural research funding and opportunity for patients and informed consent, et cetera. So it's not an immediate process by any means.
Is that going to be discussed at the NIH or elsewhere right now as a result of that?
I imagine it might be.
No, in a typical ECT treatment, how much current is given to a patient and over what period of time? Is there a range that you can give me on that?
Yes, there is a measure of energy called...
I think they don't have that.
There is an energy measurement called the joule, and this is how most machines are measured and calibrated. There's very, very good evidence to show that there is a range at which most people will have seizures. And this has been reasonably well studied, and most practitioners use current stimulations that deliver approximately 60 to 100 joules, although this varies somewhat. But I must emphasize again that even though this may seem like a fairly large amount of energy, only 2 to 4% of it actually gets into the central nervous system.
Is there a way to compare that to household current?
It's a very difficult thing to compare to household current because the amount of current you deliver depends on, I'm just trying to think of a reasonable analogy.
Well, I just wonder if you got a shock from something in the house, it would be more or less than what you get from the...
If you're talking, I think the best analogy I can give to put it in perspective, the FDA has set up parameters for implantable devices into the brain for blind people, for example, to stimulate so they might see some spots of light. And the amount of electricity that comes into the brain from electroshock therapy is well below those limits set for those machines.
So you can't say compare it to household current?
Well, I would love to make a simple analogy, but it is very, very difficult to do that. And I think we can only talk about the amount of current that is actually impacting on each neuron. And I can simply say that the amount of current that impacts on a certain surface area of the brain is well below the standards that the FDA has set for chronic implanted brain stimulators.
How many joules are applied to the base of a 100-watt light bulb as opposed to the neurons in the brain? Is that a fair question? If it isn't, just tell me.
It is not a fair question because everyone focuses on the joules delivered by the machine, and a very small proportion of those joules actually get into the central
Well, that's what I was
nervous
asking specifically, are end up being actually applied to the neurons. How many joules end up actually being applied to the neurons of the brain as compared to the surface of a 100-watt light bulb?
If you look at the joules that enter the central nervous system, it's probably 2 or 3 joules over billions and billions and billions of neurons. And when you divide that out and look at the amount of joules, you get a very low level of stimulation.
I would like to say I gave this panel information on Thymatron, electroconvulsive devices, that maxes out at over 200 joules. That's over 148 foot-pounds. It means that the total maximum possible energy delivered to the skin, head, and brain would lift a pound weight 148 feet in the air. Now, how much of that goes through the neuron is a different question.
Dr. Weiner, do you know what watts would be in a light bulb? Can you?
Well, if you had a 100-watt bulb, it would barely flicker at all, probably not at all, with the kind of intensities that he's talking about actually to reach the central nervous system.
15-watt bulb would flicker? That's what they want.
The data that I gave to them this morning, it comes out in a half a second, it's 360 watts.
I want to thank you for your time and your patience.
Could I please ask, I want to ask something about memory loss. Is it cumulative with the more treatment the patient has?
Ladies and gentlemen, one moment. The ad hoc committee for a moratorium on electroshock is going to conduct a press conference, an alternative press conference, right here immediately following this press conference. At this press conference, Dr. Peter Bregan, Dr. Edward Hopkins, and survivors of electroshock will be available for any of your questions, as long as you would like a question.
What would be wrong with you all saying that 15% of people have delusions?
Because it's just really erroneous. And then everybody starts calculating. Nobody knows. You don't know what percent
But see,
response.
the opposite effect you get is what this guy over here said, which you weren't afraid of. You got to say you all don't know anything.
But that's one of the things about research is that truthfulness. It's not very much like it's not very much.
You know more about the incidence of depression.
So do you have a master?
I have one.
Okay, I don't want to see. Yeah. I don't want to see it. That's
well, I don't know if there's a master. All right.
Does anyone ask?
I'm going to be trying. But I wasn't actually having an hour. You'll be better. I'll still here. So. All right.
Yeah. I assume there must have been something on
there. Probably next week. I'll give you a call to coordinate.
That's all you do. Go back.
I'm a graduate physicist. I could ask questions on that.
But then you divide that by, for 2% gains in the brain,
Okay, 100
and
watt
spread
light.
out all
That's
neurons.
one. Tear up your wiring here.
Don't, please. I like my wiring.
Good.
So a watt is 1 joule per second, so a 100 watt light bulb gets 100 joules per second to light it up.
Yeah, that's really
That's freshman physics.
Yes, high school physics.
Everybody's physics, right?
Right. And what's your name, sir?
I'm George Murray. I used to be a physics teacher.
Oh, yes, I am right now. If I get back to give my students their final exam.
I know it.
Everybody from the press, anybody want the alternative material?
Well, thank you. It was
I'll give you a statement here. Well, we'll do it.
If you're interested, we'll do it for you alone. Now, we have some important things to say. Peter Reagan is here.
Gentlemen, these are panel members of the consensus. Quiet, please.
The conspicuous absence of electroshock critics and survivors on the conference panel and its domination by pro-shock mental health professionals discouraged public debate. Its deliberations are therefore highly suspect. The committee, composed of mental health professionals and former psychiatric inmates, including electroshock survivors, opposes the use of electroshock. Our committee believes the following points must be made in any full and complete discussion of electroshock. 1. Electroshock always causes permanent brain damage. 2. Electroshock always causes permanent memory loss. 3. Patients' reports of memory loss and other severe effects, including loss of creativity and the inability to learn new material, are systematically ignored or denied. 4. The quote, improvement described by the shock doctors, confusion, apathy, and euphoria, is actually the result of the organic brain syndrome caused by electroshock. 5. Electroshock causes more suicides than it prevents. Ernest Hemingway is only the most famous example. 6. Electroshock causes a small but significant number of deaths. 7. Electroshock has never been proven to have any long-term, quote, therapeutic effects. In fact, no study shows that these effects persist more than 30 days following the last shock. 8. Informed consent to electroshock does not exist because shock doctors deny the procedure's harmful effects and because psychiatric institutions are inherently coercive. 9. None of these statements has been disproved by the American Psychiatric Association or the Consensus Development Conference. 10. The burden of proof must be on the shock advocates to scientifically and conclusively demonstrate the safety and efficacy of electroshock. The Food and Drug Administration should not grant the APA's petition to reclassify ECT devices from its current high-risk class to a lesser risk class without conducting a full-scale public investigation. For these reasons, we call for an immediate
moratorium on electroshock. At the conclusion of our statement, we have people available to answer your questions. I would like to say that after listening to what I've listened to for the last hour, I have been through 3 of the types of depressions that they have described. The severe, persistent depressions with loss of motor activity, with apathy, with physical bodily delusions, with the inability to work. The first of those depressions, I was hospitalized. I was given large dosages of psychiatric drugs. I was not fortunately given electroshock. I did not recover from that depression until 5 months after the hospitalization, after I had gotten myself off the drugs and was able to recover spontaneously. The other 2 depressions, which were severe but of much shorter duration, I recovered from spontaneously without psychiatric. Do you have a copy of that?
Yes, we have many copies of it. Are we available? Leonard does.
Thank you.
Thank you. Any questions for any of us? Dr. Reagan, Dr. Frank, myself?
I got you.
Very good.
But the point is, that these people don't believe in psychiatric treatment at all.
There is some
I want you to hear that too. You heard that? You think
I need to go.
One of the most significant various studies showed that closer people were to the treatment, more acceptable.
Why don't we work our way out?
People had it, the families of the people, as opposed to the general public. The general public was against it. And then you have this group that we've seen on very much who have nobody knows. You have epidemiological tests. My guesstimate would be that they were
Well, a lot of them got it years ago, and that's not fair either.
But unfortunately, when you have information gathering by testimonial or by having one group of people collect everyone who comes forward, it gives a distorted view of the actual.
Start to be used, that's what I was going to ask. Because, and I assume when we say unmotivated, we just clamp on the head and give them a shot.
They meant that they didn't give the non-muscle relaxants or anesthesia.
Okay, so how long have you been using that?
20 years, I would say, roughly the 60s.
The other thing is the other day,
Take care of it. I'll be in touch.
Yes, Chris.
They didn't tell you the time in which it was.
Oh, you mean the amount of...
Most of the people, most of my friends who I talked to thought that that was a current state hospital. But actually, it was a state hospital in 1952.
Right.
And they didn't say that. Usually in documentaries, they'll say, so-and-so, 1952. They didn't do that. There was no
So
indication.
people thought that was the way ECT was being given
Most
when
people in
the
the
movie
public,
came out.
most people in the public, if you ask them, thought that's the way it was today in Oregon State Hospital. And in fact, there's no mention in the movie.
Nest was such a brilliant movie.
Get your comments on Cuckoo's Nest tonight. This is a subjective interest. What did you think about Cuckoo's Nest?
I think Cuckoo's Nest is probably, next to Casablanca, the greatest American movie.
If I told you that it almost exactly duplicated my personal experience, do you think that I'm lying to you?
Absolutely not.
Because it does.
For me to say that there hasn't been coercive psychiatry is a lie. I know there has been. And our job, those of us who consider ourselves ethical psychiatrists, our job is to try to get rid of that coerciveness. But the point is that these, I guess you're with them, don't believe in psychiatric therapy at all. So, I mean, we're not able to have a dialogue. I mean, if you basically don't accept that mental illness exists and that drug treatment, for example, is a very effective thing to do, then there's nothing for us to have a dialogue with.
Yeah, but you understand that there are members of your profession that with the phenothiazines now, the literature shows, but the literature now shows 30 upwards of 30% for long-term use of tardive dyskinesia. And that funny jerking that when it was being given to me, the psychiatrist wrote down as a symptom of my illness.
You understand what I mean? These problems
I
have
understand.
existed.
I understand.
And in looking and willing to find people to be a friend when you need a friend and with their professional expertise. But the profession itself has had some very serious problems in breaking the trust that naive people have put in.
It's
Not
like
that
the
it's
surgeons in
everyone.
the 14th, 15th, 16th century that cut people's legs off without any anesthesia when they had to. I mean, what happened since 1935 with convulsive therapy, for example, before modification was the only first one I ever saw was unmodified, and I thought it was a medieval torture. And I wouldn't do it if we didn't have modification. I mean, no, then it would be it'd be a very difficult thing. But what you say if you deny all psychiatric therapy, ECT, drugs, is that you're advocating euthanasia because you're saying that the severely mentally ill people have a right to snuff themselves rather than someone else doing it for them. And I say that that's no different than having Nazis come in, line you up against the wall and shoot you if you're a chronic mental patient.
I understand the concern you're using. From where I've seen that rationale for a profession used to protect people that express anger in the implementation of their treatment.
People that are mentally competent, and I let the legislature, whoever wants to make that decision, make it, have an absolute right to refuse treatment. As long as they're not eminently dangerous to someone else, and I think to themselves. Now I realize that Saz and Dr. Bregan have different views on danger to self, but if I know that someone is psychotic and they say that they're going to go out and axe murder somebody, I can't let them do it.
Why don't you lock them
gonna
up in the jail?
Huh?
That's the thing to do with axe murderers, lock them up in the jail.
Not if they haven't done it.
Well, I think a threat is illegal.
No, it's not.
A threat to somebody's life is
It's not illegal unless it's made in it's not illegal to threaten someone's life as long as you don't do it in a way that indicates you're eminently right now going to do it. If someone were just say, well, I'm going to get rid of Dr. Bregan, that's not you can make any threat you want.
No, but
if it's
that's
vague and
not what you said.
non-specific.
You said if somebody told you they were going to axe murder somebody.
But if I have the conception that they're ill.
Now wait a minute, we're changing the subject, aren't we?
Then I'm not going to put them in jail.
Well, why shouldn't someone who is incapable of, in fact, you know that many psychiatric wards are less comfortable than jails.
No, you haven't been in Texas jails.
Hey, are we? Well,
say the difference is that you don't believe in mental illness, and I do. So we can't have a doctor.
Well, no, I didn't say that.
Well, I'm not saying you, but I mean
it's been misused. It's been misused.
If it's used as an agent of social control, that's absolutely wrong. People should not be deprived of their freedom because they're different. They should not be deprived of freedom simply because they're crazy. Even if just because they're psychotic, they shouldn't be deprived of their freedom. People have the right to be psychotic.
But look, they have been deprived of their freedom because they're different, haven't they?
I'm not saying they haven't. What I'm saying is that you lump all of us into one bag, just like I could lump all of you into one bag, and I don't do that.
Have you ever deprived
I think on both cases there's more tolerant and respectful.
Like I told CNN News, I don't doubt that you have had a very bad experience with ECT. I'm not saying that you made that up. I don't say it's because of your illness. I think you had a very bad experience, and I'm sorry about it.
You know about my experience.
No, I don't.
Well,
but I'm saying that the people here who say that they had a bad experience, I've never given insulin.
Okay, that's another type of brain damaging. All the brain damaging procedures you call safe and effective. I know your history, and it stinks, and it's full of brain damaging, oppressive treatment, so-called treatment to people. What psychiatry should be called is actually a good example of abuse. That's all it is.
So I say we can't have a dialogue when we have those kind of differing, polarizing opinions.
We tried to dialogue with you guys, but you guys think you have all the answers. That's why you say
I don't. So you're making the same mistake that you accuse psychiatry of making. You're lumping me in with everybody else.
Well, I heard you loud and clear at the conference. You were a supporter of shock, and that's good enough for me.
Because I see a lot of people that get better with it.
Because you're into damaging brains. That's
One electroshock treatment can equal the energy of 3 pistol shots to the head.
Dr. Rose accepted 2 pieces of literature for reference. I hope you might make copies available for the panel. We're talking about having a police factor information on the device and what we're using. And the one copy is the Thymatron, the brochure on a single sheet handout on the Thymatron pulse ECT device. And in there it shows the physical characteristics. I also included a current Winchester ammunition catalog because it shows the energy with which the bullets have. But running this machine at its maximum brings 201 joules of energy. That is 148 foot-pounds. If you're interested in actually understanding, like the truth in lending and what they're talking about, 1 joule is 0.07376 foot-pounds. But what this means is this device, when operated at its maximum capacity, will lift a 1 pound weight 148.7 feet. The energy contained in that is equivalent to 3 25 caliber pistol slugs. Now that is just pure factual data. To give that lifting of 1 pound energy equivalence in informed consent, how could you not do that? And if you're going to give a procedure, the total energy and the total time are the physical parameters that characterize the device. How could you not include that information? And if a doctor prescribes a drug, he has to record the prescription. Why isn't the total time and the total energy recorded? This has been an experimental hazardous device for years now. Why hasn't this information been gathered that we could be talking with concrete objective facts rather than subjective opinions of psychiatrists and patients?
One electroshock treatment can equal the energy of 3 pistol shots to the head.
All right, out with your gun. Out with your gun.
Okay, this won't hurt. It'll be over in just a moment.
Uh-huh.
What's that?
Conductant.
Oh, dab will do you. Right, Mr. Jackson.
Open your mouth.
What's that?
This will keep you from biting your tongue.
Well.
Now just bite down on it.
Oh.
That's right. Just bite down. Now bite down on it.
Good. Are you ready? Here we go.